Good evening, everyone. How are you all? All right, guys. So today we are going to finish ENT. So we finished ophthalmology in our last class. So for ENT, there are not much to discuss. So few chapters are there in John Murtagh. So first of all, I'll show you from John Murtagh which are the main two chapters that we're going to go through. So if you come to John Murtagh, you will see that there is a chapter 33, which is deafness and loss of hearing. That's the one of them. Few ENT related topics are there in dizziness, vertigo, and then you also do the painful ear. So these are mainly the three chapters that we do. So chapter 33, 35, and 39. And sometimes we also ask you to go through few of these chapters like nasal disorders. And you can also have a look like sore mouth, sore throat. These are not something that we discuss in the class, but you can definitely read it in your own time. We will discuss a little bit from sore throat, mainly tonsillitis and quinsy, but otherwise you'll need to go through this. So chapter 61, 62, you have got painful ear, chapter 39, chapter 33, deafness and hearing loss, okay, and dizziness, vertigo, which is chapter 35. So we're going to start with the painful ear chapter, which is chapter 39. Excuse me, guys. So, first of all, we are starting with the painful ear. So, otitis media in children. So, that is the main common cause of presentation in a general practice setting for children with a ear pain. So, there is acute otitis media and then chronic otitis media. So, acute otitis media is very common. It is one of the most common reasons a child is brought into medical attention. Common in school-going children. Sometimes even upper respiratory tract infection can be associated with a ear pain. Most of the time it is bacterial, so 2/3 of cases. And the commonest organism which causes acute otitis media is Streptococcus, Haemophilus influenza, and Moraxella catarrhalis. So the main symptoms in children will be earache and sometimes loss of hearing. If it is infant who can't say that I'm in pain, they can start pulling their ear. So for infant, pulling the ear is one of the signs that something might be wrong in their ear. So if a child coming to you with ear pain, loss of hearing, maybe sometimes even a bit of discharge from the ear, you would look into the ear by a otoscope to look at the tympanic membrane. And if tympanic membrane looks inflamed, that is what you need for the diagnosis of acute suppurative otitis media or ASOM. Okay, so sometimes what happens that initially the patient will come to you with a blocked ear feeling, and then it will get into ear pain, fever, and sometimes if it is too much pus accumulation inside the middle ear, the tympanic membrane can burst, followed by relief of the pain and fever. So if tympanic membrane perforate, then patient will also have this discharge, like a sudden gush of fluid coming out of the ear, and then the pain will get settled. So that's also one of the other presentation. As part of virus, the common virus which causes otitis media is adenovirus and enterovirus, but most of the time it is bacterial. The two cardinal features to diagnose ASOM is inflammation and middle ear effusion. So diagnosis is redness of the tympanic membrane. So when you look at the tympanic membrane by otoscope, If it looks red and inflamed, that's the diagnostic feature. So tympanic membrane will be red and inflamed with engorgement of the vessels. Loss of light reflex can be there also. Tympanic membrane can look bulged because there is lots of pus or fluid getting accumulated. So what will be the treatment? So once you diagnose that child is having ASOM, treatment, it varies. If it is associated with a viral infection, with a mild reddening or dullness of the tympanic membrane, then antibiotics is not needed, especially if the child doesn't have fever, vomiting. So if the child having a bit of coughing, then also a bit of runny nose, mild fever, probably just a viral infection. And then along with that, you have found that there is a bit of redness of the tympanic membrane. Okay, but there is no fever, vomiting, so no associated systemic symptom. In those patients, usually we don't need to go for antibiotics. So just symptomatic relief with painkiller, and you can just wait and watch. And this is usually for children who is 6 months or more than 6 months older. Whereas if the eardrum looks very red, yellow, bulging, and child having fever, vomiting, then antibiotic is indicated. So this is what's the indication of antibiotic for children. So if a child already got another ear is already like they can't hear from the other ear. So if there is acute otitis media in the only hearing ear, or someone who had cochlear implant or indigenous children, for them you will start antibiotic right away. For other children, you will only start antibiotic if the tympanic membrane looks very red and inflamed with child having fever, vomiting. And let's say you have tried conservative approach, wait and watch. And even after 48 hours, child having persistent fever and pain, still antibiotic should be started. So basically, if the child will need antibiotic if it looks red and inflamed and there is an associated fever, vomiting. So amoxicillin is the treatment of choice. And if amoxicillin does not work, you can add amoxiclavulinic acid. If patient is penicillin hypersensitive, then cefaclor will be the choice of treatment, or cefuroxime. If you're giving the appropriate antibiotic, children should get improved within 48 hours. So if the child doesn't get better within 2 to 3 days of antibiotic, you need to ask the parents to bring the child back. So that's the management for acute otitis media. What are the complications? So sometimes or most of the time, acute otitis media will get better with antibiotic, but some of them can get complicated. So some of them can have a long-term middle ear effusion. So 70% of children will have an effusion at 2 weeks, and only 10% can have a persistent effusion more than 3 months. So ideally we say that, let's say the child got an acute otitis media and you have given antibiotic. If child having a bit of loss of hearing or maybe a bit of pain on and off, and you checked the ear again, if effusion is still present by 6 to 8 weeks time, then a second course of antibiotic should be given. And if effusion persists more than 3 months, then you will need to send the child for a ENT opinion, especially if there is a associated speech delay. So again, if effusion persists more than 3 months, ideally, we would send the patient for a ENT opinion, because many times they might need to have a grommet to allow drainage of this effusion. What else can it be? Acute mastoiditis can be there. So the mastoid bone, which is just at the back of the ear, that bone sometimes can get infected. And how we would know? The child will have swelling and redness and tenderness over the mastoid bone. So if the child having swelling, redness, and tenderness over the mastoid bone, then you would suspect acute mastoiditis. If you suspect mastoiditis, you need to send the child immediately to the hospital for IV antibiotic. Sometimes ASOM can get complicated by CSOM. So if there was a perforation and patient having continuous or persistent discharge through that perforated tympanic membrane for more than 6 weeks. So discharge through a perforation of tympanic membrane persisting more than 6 weeks is known as CSOM. There is serous otitis media or glue ear. So glue ear and middle ear effusion is more or less same. So the glue ear is nothing but an incomplete resolution of the suppurative otitis media. How we diagnose glue ear? Children will have an initial episode of ASOM followed by loss of hearing. And when you get loss of hearing and you can see there is fluid inside the tympanic membrane, you would know that this is most likely a serous otitis media. Most of the cases, this serous otitis media should be resolved by 3 months. If it is more than 3 months and child having hearing loss, first you will send the child for a hearing assessment. So you will send the child for a audiometry and then refer the child to a ENT for possible gromets. So you can see the management is same. The only thing in here, there is a hearing loss associated with the effusion. So if there is a loss of hearing associated with the effusion, then you're going to send the child for a hearing assessment followed by ENT. And the picture that you see over here, that is mastoiditis. Next, chronic otitis media. Chronic otitis media means that, as we already know, that if there was a perforation and the discharge persisting for more than 6 weeks through the perforation, that becomes CSOM. There are two types of CSOM, and both of them will present to you with chronic discharge with deafness. But they will not have any pain. So the main presentation is deafness and discharge. Now, one is called safe CSOM and another is called unsafe CSOM. The unsafe one is complicated by a condition called cholesteatoma. Now let's talk about chronic discharging otitis media, which is the safe one. So we normally say the safe one is the one that happens in the middle, like this one. So if it happens in the pars flaccida, that's called the safe ear. If it happens in the pars tensa, on these areas, that's most of the time we call it as unsafe CSOM. So what is the treatment? It's easy to diagnose because you will get perforation, you will get discharge, and child will have deafness. That's CSOM. And if you see there is a perforation in the middle part, that's safe ear. So if oral discharge persists for more than 6 weeks, after a course of antibiotic, the treatment will be with a topical steroid and antibiotic drop, following ER toileting. So normally what we do is that we do the oral toilet, which means that removing any existing discharge can be done with a multiple thing like dry mopping, with a rolled tissue spear. So there are lots of ways to do that, but oral toileting should be done first, and you remove the existing discharge and then start the patient with a combination of steroid and antibiotic drop. That's the treatment for CSOM. Which antibiotic drop? So ciprofloxacin, we don't give gentamicin because it can be ototoxic. So ciprofloxacin is ideal, or sometimes even if the child is not having If the child is not having perforation, then we use other ones, but with the perforated one, ciprofloxacin is the ideal one. Unless we know, so you will do the, if you start the patient with, let's say that you start the patient with ciprofloxacin and it's not getting better, then if you take a swab from the discharge and if then it comes as a pseudomonas, then you would think of that. But it's not that just because of greenish discharge you will start them with gentamicin. You will take the swab first, get a diagnosis, and then start it if needed. But the initial would be always cipro. So if you look over there, so this is what we call as cholesteatoma. And cholesteatoma will be seen that there will be a perforation, but you will see this kind of whitish debris. So it's a collection of debris, wax, squamous cells and everything causing this growth, which is what we call as unsafe ear. The problem with this accumulated squamous epithelium is that this can cause erosion of the bone. Okay, so if it causes erosion of the bone, that can be quite bad. So cholesteatoma is visible through the perforation as a white flake. Okay, and most of the time this will have like a foul smelly, but the discharge will be a scanty amount. But that discharge will be quite purulent. So cholesteatoma, it will, like when you will try to look inside, you will feel you'll know, like you will smell a very foul, offensive smell, and then you will know that something is not right. So if you suspect that there is an attic perforation, or if you suspect there is a cholesteatoma, you will need to send the child to an ENT specialist. Remember, if it is cholesteatoma, it will need a surgical removal. There is no medical treatment for this. Okay, so far clear, everyone? Any question? Okay, moving on to otitis externa. Otitis externa means the infection is not in the middle ear, but in the external ear. So it is also known as swimmer's ear, surfer's ear, because patients who do a lot of surfing and water sports, they tend to get this otitis externa. So the common organisms, so for otitis externa, Pseudomonas is common. E. coli, some fungi can also cause this, like Candida or Aspergillus. So how we know that a patient might have got otitis externa? So your patient will come to you with an itchy ear. So first itchy ear with otalgia or painful ear. So itchy, painful ear. They will always complain that they feel full in their ear canal, and because it is blocked with a lot of inflammation and everything, patient can also have muffled hearing or hearing loss. Very easy to diagnose. If you look into the external ear, you will be able to see the external canal is swollen, inflamed, and sometimes even it looks a lot of discharge will be there. Okay, so itchiness first, followed by ear pain, ear fullness, loss of hearing, and then when you look into the external canal, it's swollen, there is a bit of a discharge there, the redness. That's the diagnosis that you look for otitis externa. So what is the treatment? The treatment, first of all, if there is a bit of discharge, you can go for oral toileting and then start the patient with topical antibiotic, antifungal, and steroid. So when the canal is open, so if you do the oral toileting and now the canal is open, you can give them a medication like Kenacomb or Sofradex, which has everything, bacterial, antifungal, and corticosteroid. Okay, so that's all about ear pain that usually comes in exam. So if you at least know what is ASOM, CSOM, and otitis externa, this chapter is done. Otitis media will not have the itchiness. Okay, but otitis externa will have itchiness. That's the main presentation. And lots of other things, like just not on the history. If you do an examination, it is very easy to diagnose. Is it otitis media or otitis externa? But itchiness is a very specific feature for externa. Okay, moving on to the next chapter. So we'll come to this just in a bit, but we'll move on to hearing loss chapter now. Dr. Protik, suppurative and acute otitis media are the same thing. So the name is acute suppurative otitis media. It's the same thing. Okay, now let's go on to chapter 33, which is deafness and hearing loss. So deafness, hearing loss, it comes in exam, but not a lot. So first of all, a normal hearing, the threshold is 0 to 20 decibel. And we divide the hearing loss as mild, moderate, severe based on the decibel. So loss of hearing at 20 to 40 decibel is mild, 40 to 60 moderate, 70 to 90 decibel severe. Okay, now loss of hearing, we divide it as conductive deafness and sensory neural deafness. So if you look over here, this is the structure of the ear. So you've got pinna and then the external canal. So that's the external part. And then we have got tympanic membrane. You can see the three bones in the middle ear. So this is the middle ear. So you have got external ear, middle ear, and this is the internal ear. Any problem in the external ear or middle ear will give you conductive deafness. Any problem in the inner ear will give you sensory neural. Okay. Now, what are the causes of conductive deafness then? So someone who is having a wax, it can cause complete blockage. So impacted wax is one of the commonest cause of conductive deafness. What else? Otitis externa, if it is quite swollen, that it has blocked the ear fully, that can cause loss of hearing. Eustachian tube dysfunction. Sometimes, definitely, like acute otitis media, chronic otitis media, serous otitis media, all of these will also cause conductive deafness. Autosclerosis can cause it. Definitely cholesteatoma can cause it. So any problem in the external canal or middle ear that gives you conductive deafness. So what gives sensory neural? Sensory neural can be a lot of conditions like acoustic neuroma, which is a tumor, then could be related to viral infection like labyrinthitis or vestibular neuronitis. Could be age-related loss of hearing, like which is presbyaciosis. Someone who works in a noisy industry can cause noise-induced deafness. If you use ototoxic drug, it can cause inner ear problem, causing this hearing loss. Then there is Meniere's syndrome as well. So these are the common causes of sensory neural deafness. So the commonest cause of deafness is impacted wax, serous otitis media, and otitis externa. So you can go through these checkpoints. You can see that some of the ototoxic drugs are gentamicin, neomycin, furosemide. So these are all ototoxic drugs. So the next question is that let's say someone having hearing loss. What would you do next? So you look at the ear, check for anything that you can see by your otoscope. Now, after you have done that, the next part is a clinical examination to check or to confirm the hearing loss. So there are three types of hearing tests that we can do. One is called whisper test, and then the other, Rini and Weber test. So if deafness is present, it should be determined by tuning fork testing. So let's talk about Rini and Weber and the whisper test also. So they haven't talked about whisper in here, but in whisper test, what we do, which is the initial screening, we just whisper 3 numbers behind the patient's ear, and we block the other ear, and we check one ear at a time, and we ask the patient to repeat those 3 numbers. If a patient is able to repeat those 3 numbers while we are whispering, that means the patient has got a good hearing. So that's the initial screening test. If that test shows that there must be some kind of abnormality, then you move on to this tuning fork test, which is Rini and Weber. In Rini test, what we normally do is we vibrate this tuning fork and we place the tuning fork on the mastoid bone. Okay? And we ask the patient to inform us that when they no longer can feel the vibration. Now, this vibration patient is hearing, is it through bone or through air? What do you think? Bone, because you are putting it on the top of a bone, right? So that means you are checking the bone conduction by placing this tuning fork on the mastoid bone. So patient inform you that I can't feel it anymore. That means there is no more vibration. And you bring this vibrating tuning fork in front of the patient ear, and you ask the patient, can you feel any vibration still? Now, if the patient say, yes, I can hear the vibration. Now, if the patient is hearing the vibration, is it bone or air? It is air conduction, right? Now, if patient says over here that no, I can't feel the vibration anymore, but when you brought the tuning fork in front of the ear, patient says, yes, I can hear them. Which one is greater, air or bone? Air, right? So air conduction more than the bone conduction. So that is normal finding for a normal ear. So air conduction more than bone conduction should be the finding that we are looking for in a normal ear. But in a sensory neural deafness, you can get air conduction more than bone conduction as well. So it is either normal or sensory neural deafness. To differentiate between these two, you do the next test, which is the Weber test. Okay. Now, what if the Rini test says, no, the bone conduction is more than air conduction? If bone conduction is more than air conduction, that is conductive deafness. Okay. So air conduction more than bone conduction can be either normal or sensory neural. Bone conduction more than air conduction, that is conductive. That is abnormal. Okay, so now that we understand Rini, next thing is Weber test. On the Weber test, again you vibrate this tuning fork and you place it, either you can place it on the forehead or on the vertex, and you ask the patient, where do you hear best? If normal patient with no hearing loss can say that they are hearing equal on the both ear or they're hearing it in the middle. So hearing louder in the middle or equal on the both ear is normal. But if patient says that no, I can hear better on the right or left ear, that's the time it is pathological. So what we will look for, now let's go to our discussion here. So we can see the Rini test, air conduction more than bone conduction means normal versus sensory neural. Bone conduction more than air conduction, it is conductive. So you've done the Weber test. If Weber is louder, that means if sound is louder in the defective ear or affected ear, where patient says that I hear less on that right ear. So if sound is more louder on that defected ear, that confirms conductive deafness. Okay, how we remember it? Defective, conductive. So conductive has a D and defected. So if sound lateralized to the defected ear, that is conductive deafness. If sound is louder on the normal ear, that is sensory neural deafness. Okay, so that's how you can confirm what you have got in the Rini test. And also, if air conduction more than bone conduction, Weber will give you an idea that is it a normal or sensory neural. So in Weber test, if patient says that I am hearing louder on the affected ear, so your patient came to you with a right-sided loss of hearing. Okay, you have done the Rini test and you found that bone conduction more than air conduction on the right ear. Then you did a Weber test and Weber says that sound is louder on the right ear. That will give you the confirmation that this is conductive deafness. Because first, bone conduction more than air conduction means it is conductive. And we know that Weber will be lateralized to the defective ear, which is the right ear. And patient also saying that I can hear louder on the right ear. So if patient hear louder on the defective ear, that confirms sensory neural deafness. Does it make sense? Excuse me. Okay, I'll just stop sharing the screen just for a moment so that we can practice one thing. Let's do a example. So you have got a patient who comes to you with loss of hearing, and then you have done the Rini and Weber. So Rini says air conduction is more than bone conduction in the left ear. Okay. Now, patient had a left ear problem or left ear hearing loss. So you found air conduction more than bone conduction. So that means it can be either normal or sensorineural deafness. Then you did the Weber test, and Weber says that the sound is louder on the right ear. So what do you think this patient has got? So we at least know that it is not normal because Weber is now lateralizing. So it is sensorineural deafness. The question is, which ear is having the sensorineural deafness? Because we know that if it is a sensorineural deafness, sound will be lateralized to the normal ear. So patient saying, I can hear louder on the right ear. That means it is normal ear. And that means the left ear is having the sensorineural deafness. So it is a left sensorineural hearing loss. Okay. So always remember that if it is a sensorineural deafness, sound will be louder on the normal ear. And if it is conductive deafness, sound will be louder on the abnormal ear. Like let's say if you do the second example, bone conduction more than air conduction in the right ear. So right ear is conductive deafness, at least. So if it is a conductive deafness, we can confirm it by doing the Weber. So if conductive deafness is on the right ear, where the sound will be more lateralized? We know if it is conductive deafness, sound will be lateralized to the defective ear. Okay, so that gives us a confirmation. So conductive deafness easy because bone conduction more than air conduction, you can be totally sure that this is conductive deafness. But the sensorineural is a bit difficult, but it's not hard. It's just remember if Weber is lateralized to any ear, there is a normal ear. Because in sensorineural deafness, sound will be louder on the normal ear. Okay, easy in that way. Okay, moving on. I hope it makes a lot of sense. Not, then let me know. So let's say you have got this tuning fork test, and tuning fork is giving you a little bit of problem. Okay, so if you, because tuning fork is just like a test, it's not a confirmation of any deafness. So once you get abnormal finding, then you send the patient for a formal audiometry. And the formal audiometry will define what is the loss and how much loss it is. So the most commonest audiometry that we do is pure tone audiometry, and that gives us an idea about the loss of hearing. And lots of others are there. Along with the pure tone audiometry, you can also do tympanometry. Tympanometry, it measures the mobility of the tympanic membrane. So how the tympanic membrane is moving, that actually is measured by the tympanometry. Many times, if a patient has got otitis media, the tympanic membrane might not move as it should be. So that also gives us an idea. Next is deafness in children. So deafness in children is not uncommon, but every children during birth, they usually will get tested for hearing. So congenital deafness can be due to a lot of factors. So sometimes could be maternal intrauterine infection like rubella, could be some of the medications patient was taking during pregnancy. Lots of things can cause deafness as a congenital diagnosis. Down syndrome baby can have congenital deafness as well. And as part of acquired deafness in children, most of the time it is a complication of otitis media. So every child will be screened at birth. And in here you can see that what are the early signs of normal hearing at 1 month, 3 months, 4 months. So if there is any concern, the child should have a hearing test. So normal screening time, one at birth, and then another one at 8 to 9 months time, and then during the school entry. What are the early signs of hearing loss? So it is very difficult because infant cannot actually say that I can't hear. So it's difficult sometimes to diagnose this at the earliest stage. But a lot of things, like if child is not responding to sounds, especially someone's voice, child is not even like when you at one year time, the child starts to understand you, and they usually look at you, they respond to the sound. Okay, so if child is not responding to the sound, there is speech delay, absence of bubbling by 12 months. So by 6 months child starts bubbling, but if there is no bubbling by 12 months, you will be concerned. No word by 18 months, that's a red flag. So if any of this happens, you will first make sure the child's hearing is fine. So how we do the screening? So for neonate and infant, the test that we do is called this AABR, or this transient evoked autoacoustic emission. You just need to remember this name. This auditory brainstem response comes in exam for neonate. That's the one you would remember. And after 4 years, you can do the pure tone audiometry with tympanometry. So before 4 years, you can use this ABR, and after 4 years, you will go for pure tone audiometry to do the hearing test. So any child with hearing loss should be referred to a ENT for further assessment. Next, deafness in elderly. The commonest reason that a elderly patient can have loss of hearing, especially sensory neural deafness, is presbyaciosis, which is age-related high-frequency hearing loss. So what is presbyaciosis? So it is sensory neural hearing loss, which is related to aging. Patient will mainly have a loss of high-frequency sound associated with tinnitus, which is this ringing noise in their ear, intolerant to very loud sound. Okay. And again, if you suspect presbyaciosis, you will send the patient for a pure tone audiometry to get the hearing test done. And patient might require a hearing aid. Sudden deafness. So sudden deafness is always something concerning. So sudden deafness is sudden sensory neural hearing loss greater than 30 decibel with an acute period of 12 hours to 3 days. So if within 3 days time patient has got a significant loss of hearing suddenly, you would be concerned. So what are the causes? Could be any trauma, like patient went for diving and then had a trauma. Then post-operative, some of the viral infection, ototoxic drug, acoustic neuroma, which is cerebellopontine angle tumor, Meniere syndrome, even a stroke can present as a sudden deafness. So that's why we are concerned, especially if it is an elderly patient, had a lot of risk factor for a stroke, hypertension, diabetes, smoker, cholesterol problem, sudden deafness, you would be ruling out possibility of a stroke, especially cerebellar stroke. So patient with sudden deafness require immediate referral because you don't know what you're dealing with. So the initial investigation will be some of the blood tests, but most importantly, if you're suspecting a stroke, the patient will need an MRI. Okay. Next, autosclerosis. The audiometry graph. Okay. Normally, I don't discuss that in the class, but can anyone share what type of questions is coming? And we can discuss that after the break. Okay. Loudness recruitment not needed for exam, so we will not go into that. And what else in here? Okay, this question we will discuss after the break. Okay, moving on. So we have got autosclerosis. Autosclerosis is a disease of the bone surrounding the inner ear. Now, it is one of the common cause of conductive deafness in a middle-aged patient, especially female. So autosclerosis means remember I have shown you those bones. So if the bone has got fibrosis or sclerosis, that's autosclerosis. So that means it is the bone of the ear rather than being rather than being bony part, the bone becomes sclerotic. Okay, so the normal middle ear bone is replaced by some vascular spongy bone, and later on it becomes sclerotic. Sclerosis means that it doesn't move. The idea of sound wave is that the sound will transmit through the external canal, it will vibrate the tympanic membrane, and then it will vibrate the ear bones. Now, without the vibration of the bone, sound cannot transmit to the inner ear. Okay, so because these bones are connected with the inner ear and also middle ear, so autosclerosis can give a mixed deafness. Okay, so these patients can have both conductive and sensorineural deafness. Most of the time it gives more conductive deafness and a little bit of sensorineural deafness. So it is a progressive disease in between 20 to 30. Sometimes family history can be there. Female is mainly affected, and it mainly affects the foot plate of the stapes bone. And sometimes you can see that during pregnancy, it can get worse. So if you do the audiometry, it can give a conductive loss with a mild sensorineural loss. So in autosclerosis, the diagnosis is you have got a conductive deafness in a middle-aged female, but the tympanic membrane is normal. That means nothing else you can find out. You can't find out any otitis externa, no impacted wax, no sign of infection, but is still having conductive deafness. Then you thought of autosclerosis. Okay. If you suspect autosclerosis, you will refer the patient to a ENT, and excuse me, ENT can do a stapedectomy. So they can remove the stapes, which is a bit of sclerotic. Okay. So that's the treatment of choice. If not possible, then we go for hearing aid. Tinnitus. So tinnitus means ringing noise in the ear. It is a very annoying condition, and the problem is you can't do anything about it. But there is a lot of condition which can cause this tinnitus. So you can go through them. So it is a sound perceived by the ear, and it feels like a ringing noise. When pathology is in the inner ear, tinnitus is non-pulsating and continuous. So exclude any of this. exclude if the patient is having wax. Sometimes marijuana patient can have like this problem, NSAID. So a lot of these conditions can present as tinnitus. But always remember, if patients say that I can feel a pulse in my ear, make sure to rule out any carotid artery lesion, especially any carotico-cavernous fistula or AV fistula. So if the tinnitus, which is non-pulsating, that's common and that's normal, and that mainly happens in patient with an inner ear problem. But if it is a pulsatile one, then you would consider like a carotid artery lesion. So those patients might require a CT angiogram, maybe a MRI to know about this condition. So if a patient has got this kind of tinnitus, what would you do first? So you send the patient for a audiological examination. So do a audiometry, tympanometry, and if you suspect any serious cause, then MRI or CT scan, especially if it is a pulsatile one. So investigation is just checking the hearing by audiometry and tympanometry. Now management, it is very difficult. So it could be like you can send the patient to a psychologist for tinnitus retraining therapy, cognitive behavioral. So lots of things can be tried, and you can even try clonazepam, zinc, beta-histine. So none of them are actually like can cure this condition. You can give it a try. That's all that can be done. Okay, so that's all about loss of hearing. How to know pulsatile? Patient will tell you that I can feel like it's a pulse, like a throbbing pulse I can feel. Okay, now there are few other causes of loss of hearing, and also few of them can present as dizziness or vertigo. So vertigo is a condition where patient feels that their surrounding is moving or is spinning, or they are spinning. So there are lots of causes of vertigo. There are central causes and then there are peripheral causes. Central causes are related to stroke, related to central nervous system, which is not part of our discussion today. But peripheral cause of vertigo is related to ear. So even a impacted wax can cause peripheral vertigo, which means patient can come to you with feeling of like the room is spinning around her or she is spinning around the room. Apart from that, there are lots of other conditions which can present as a peripheral vertigo. One of them is vestibular neuritis. Vestibular neuritis is, again, it is divided as labyrinthitis, which is infection of the labyrinth in the inner ear, and it could be also vestibular nerve infection, which is vestibular neuronitis. Okay, so one is vestibular nerve infection, that's vestibular neuronitis, and another is labyrinth infection, which is labyrinthitis. Both of these can happen with a recent viral illness. So patient had a viral infection and now coming to you with a acute vertigo, nausea and vomiting, but there is no hearing loss, no tinnitus, you can think of vestibular neuronitis. Again, patient had a recent viral flu-like illness and now having a sudden acute vertigo with nausea, vomiting. And definitely you will rule out any central causes of vertigo. And if there is ruled out, you can diagnose them as vestibular neuronitis. So that means vestibular nerve is infected because of that virus. Vestibular neuronitis does not cause hearing loss, whereas if the patient has the similar symptom, had a viral infection, now having vertigo, nausea, vomiting, With that, they are also having hearing loss and or plus or minus tinnitus that becomes acute labyrinthitis. Okay? So characteristic feature of vestibular neuritis is single attack of vertigo without any deafness or tinnitus, preceding flu-like illness, abrupt onset with vertigo, ataxia, nausea, vomiting, last for days to weeks. So the treatment is just give something which can help her or help the patient with the vertigo. So you can give them estemetil, which is the commonest one that we use, which is prochlorperazine, promethazine, or diazepam. Okay, so that's the treatment of choice for this vestibular neuritis. So if the vestibular nerve is infected by a virus, patient will have acute vertigo, nausea, vomiting without any hearing loss or tinnitus. If patient having hearing loss and tinnitus, then it becomes labyrinthitis. The treatment will be same. So labyrinthitis and everything, these are inner ear. So if there is a problem in the inner ear, it causes sensory neural deafness. So labyrinthitis, vestibular neuritis, this will cause sensory neural deafness. So neuritis, we don't usually use the term neuritis because it becomes confusing. But vestibular neuritis, it has two types. One is vestibular neuronitis and another is labyrinthitis. Okay? So forget about neuritis because it will just make you a lot of confused in the exam. Just remember labyrinthitis and vestibular neuronitis. Next. Another condition which causes vertigo is benign paroxysmal positional vertigo. So this chapter I already told initially what are the chapters we are doing. So this is the dizziness and vertigo chapter. I think it was chapter 35. Have a look on the JM, the chapter should be dizziness or vertigo. So BPPV or benign paroxysmal positional vertigo, it is also an acute vertigo, but it is positional. That means whenever they change their position, especially their head position, they get this kind of a sudden episodes of vertigo. It also brings by, if they tilt their head backward, they change their position from recumbent to sitting position, or they're turning to the affected side. Very easy to diagnose because, first of all, it is common in elderly patient, and each of these attack is brief, lasting for 10 to 60 seconds, and then it gets better rapidly. So patient will come to you with a sudden onset of vertigo, but the vertigo is not at rest. Whenever they move their head, can be upwards, can be to the side, they get the vertigo, last for few seconds, not more than 60 seconds, and it gets better. And it can keep on happening every time he or she moves the head. Now, these attacks will not be accompanied by any vomiting, tinnitus, or deafness. Maybe a bit of nausea can be there, but there will be no tinnitus, there will be no vomiting or deafness. Okay, so that will actually rule out a lot of other conditions, right? So if you have got an elderly patient having a positional vertigo, that's BPPV. How to confirm it? So you can confirm it by a test called head impulse test, or a very common one we do is Hall-Pike maneuver. So you don't need to know how to do this, just remember the name. Head impulse or Hall-Pike. How to treat? So the treatment will be similar like the labyrinthitis or neuronitis. So the initial episode, you will be treating them with prochlorperazine, promethazine, or diazepam. And you will need to send them to a vertigo physiotherapist who can do some exercise to help bringing back those otoliths, which is the ear particle that has got dislodged. Which means that BPPV is mainly caused by dislodgement of some of the otoliths, which are ear particle in the inner ear. And because of this displacement or dislodgement of this particle, patient, whenever they move, those particles also move and causes the vertigo. So you'll need the patient to be seen by a vertigo physiotherapist who can help in replacement of this otolith back to the normal position. Okay, so that's the treatment. Next, Meniere syndrome. Meniere syndrome is caused by excessive accumulation of endolymph. So let me show you what is endolymph. Okay, it's not quite visible over there. Let me see if we have put anything. No. Okay, let me just bring that picture here so that I can show you. So if you look over here, you can see, so this is the normal inner ear and this is the Meniere's inner ear. So the inner ear, you can see over there. So this 3 is the semicircular canal, right? Then you have got cochlea and everything. So this semicircular canal and almost all of the inner ear, they have this fluid. And this fluid keeps the balance and keeps your balance of the ear. And sometimes what can happen is that a patient can have increased amount of fluid in this inner ear. When there is an increased amount of endolymph, then the patient can start to get a fullness in their ear and it can start to cause imbalance because of this excessive fluid in their inner ear. So that's mainly what we call Meniere's disease. The pathophysiology is quite, you can say, quite complicated, but all you need to remember that Meniere syndrome is mainly caused by excess build of endolymph in the inner ear. It's common in between 30 to 50. If a patient presents in this age group with a sudden paroxysmal attack of vertigo, tinnitus, nausea, vomiting, sweating, pallor, and deafness. So the onset of vertigo will be quite abrupt. Patient might even fall, bedridden for 1 to 2 hours, will not move their head, and it can last for several hours. And then patient will be completely normal after that. So sudden attack of acute vertigo, tinnitus, nausea, vomiting, sweating, pallor, and deafness. This sudden attack is not found in any other ear condition. Okay, so if you got a sudden paroxysmal attack of something like this, you would be concerned of Meniere's. You can even see nystagmus during the attack time. So if you examine this patient, you will get sensory neural deafness because the problem is in the inner ear. If you do a calorie test, there will be impaired vestibular function. And sometimes you can also do an electrocochleography where you will get some changes. So in Meniere syndrome, the treatment depends. So in the acute attack, you can give them You can give them prochlorperazine suppository. You can give them urea crystal or even diazepam. So any of this can be given to treat it. So prochlorperazine, urea crystal or diazepam. Sometimes even you can combine diazepam with prochlorperazine. Now, if a patient has got persistent symptom and it's getting more and more, then you can also consider giving hydrochlorothiazide. So thiazide is a diuretic, so it can reduce fluid accumulation. It can also reduce fluid accumulation in the inner ear. So hydrochlorothiazide will be another choice of treatment if a patient has got this kind of Meniere's syndrome happening very persistently and causing a lot of trouble for the patient. As a long term, the low salt diet is the mainstay of treatment, because if you give more salt, there will be more fluid accumulation. And also we put the patient on diuretic to reduce this fluid. That's a long-term treatment. Okay, so that's all about Meniere's syndrome. So I was actually discussing this dizziness and vertigo chapter. Chapter 35. So we talked about vertigo, what are the causes, you can go through them. So you have got peripheral causes, central causes. Excuse me. So dizziness or vertigo in children doesn't come in exam, so don't bother with that. So we talked about vestibular neuronitis and labyrinthitis. Excuse me. BPPV, Meniere's. Yeah. So that's mainly all that we need to go through from this dizziness or vertigo chapter. Any question, guys? Excuse me. Okay. So we'll take a 10-minute break now. And after that, we'll see if we can discuss a little bit about that, the audiometric graph. If any of you can share a question, that will be easier. Otherwise, we'll just go through this. And then we will go for some imaging. So we'll discuss CT and X-ray today. Okay, thank you. All right, everyone, let's start. Okay, few things came up. So that audiometry thing, right? So audiometry, it is a quite complicated thing to go through. Normally, they should not ask for those complicated thing in the exam because it is really difficult for someone without a audiology knowledge to interpret a audiometry. I can give you a bit of an idea, but again, it can be quite complicated. And I don't believe that they are giving you a very difficult questions from audiometry. Very unlikely. The one Dr. Mitra has shown, that is a simple question. But if you're asking me to discuss audiometry, it is quite complicated. I can discuss it, but I don't know like how much you will be able to understand. So let's see. So there is a difference between the audiometry that normally we do and the audiometry Dr. Mitra has shared. So if I open Dr. Mitra's that one, you see over there the discrepancy is that it's only showing two symbols. For right ear, just one symbol, which is just a rounded symbol, and then for left ear cross. It is not usually done by this. So audiometry will have four symbols for just like how the JM has shown here. You can see. So that's usually the audiometry four symbol that we normally would use. Okay. So that is a bit different. The question over here, that's pretty simple. 60-year-old, it's an elderly patient having hearing loss with a graph of his audiogram. If you look over here, they're saying that this is the right ear. If you remember, the normal hearing is more than 10 decibels. So anything above 20 decibel, if the hearing test goes above 20 decibel, it is normal. So if we see over here, normal right ear definitely above 20 decibel, so it is normal. But the left ear, whether like around 500 and 1000 hertz, it was still normal. But with high frequency, like 2000, 4000, it has got gradual decrease, right? So left ear definitely has got some hearing loss. Now, what kind of hearing loss? I can't say based on this graph, whether it is conductive or sensory neural. For 60-year-old having this kind of hearing loss, and you can see here that the right side has a small soft wax. The right is not a problem, right? Because right ear is fine. There is the left ear should have a bit of hearing loss. So it is not related to wax, and a soft, small wax doesn't cause hearing loss. So this is just kind of like a trap. So for a 60-year-old having hearing loss, you would be considering an age-related hearing loss without any other symptom. So if patient doesn't fulfill the criteria for any other symptom, like no other vertigo, no tinnitus or anything like that, then yes, it is most likely just a presbyocusis or age-related hearing loss. From this kind of like information and from this graph, this is the only thing that you can count. Okay. Now, if you look on this one, that is a bit confusing and can be quite complicated also, but I will try my best. So if you look over here, so first of all, have a look, there are four symbols. For right and left ear, air conduction is like this. For right and left ear, bone conduction has a symbol like this. So one is like this and another is like that. First, look at the right ear. So we know for the right ear, that's the air conduction. So that's air conduction and it is above 20 decibel, right? That means that's normal. And for right ear, bone conduction is also above 20 decibel. Okay. So when something is above 20 decibel, that ear is normal. Whether bone or air conduction is higher than something doesn't matter. If more than 20 decibel, that ear is normal. So you can at least say that right ear is perfect. For the left ear, there is some problem. For the left ear, we can see that this is the left ear air conduction. So air conduction definitely reduced up to 75. So that's air conduction, 75 decibel. And what is left ear bone conduction is that. So bone conduction is above 20 decibel. Like you can say mostly between 10 to 15. So bone conduction is 10. So which one is higher? Air conduction more than bone conduction? Can we say this is normal? No, because if it was normal, then this would be also above 20. So if it is not normal, then what it is? Sorry, my apologies. Air conduction 75 and bone conduction 10. That means in here, bone conduction is more than air conduction. You have to understand that this is not defined by the number. Rather, patient can hear at 75 decibel, which means you need to you need to have more louder sound for this patient to hear through the air conduction. That means air conduction is like severely disturbed, 75, where with just 10 decibel, patient's bone conduction is working. So which one is better? Bone conduction is better, okay? So bone conduction more than air conduction in the left ear. So if we know that bone conduction more than air conduction, that means it is a conductive deafness. Okay? So that's why we're saying severe conductive deafness in the left ear. Does it make sense? Okay, to repeat this, Dr. Sondas, so the main part you need to look into is that which one is better. So if you have understood the Rini and Weber, then it will become easier. If you don't understand Rini and Weber, then it will be very difficult. So ideally, above 20 decibel is normal. So if you see over here, the right ear has got both air conduction and the bone conduction above 20 decibel. That means right ear is normal. If we look at the left ear has got air conduction at 75. That means that patient needs a very loud sound at 75 decibel for the air conduction to work. Whereas the bone conduction of the left ear, which is this, around 10. So we can see that patient bone conduction is working at 10 decibel, whereas the air conduction working at 75 decibel. Which one is better? Definitely bone conduction is better because they need just a soft sound for the patient to hear. So bone conduction more than air conduction on the left ear, that's conductive hearing loss. Okay. Now, there is still, if you want to know a little bit more, I want you guys to go through Geeky Medics. So let me just. So if you write Geeky Medics audiometry, then there is a good discussion about this audiogram. So you can go through this The only thing that I want you guys to understand that there is a thing called air-bone gap. So if air conduction and bone conduction has a gap of more than 10 decibel, it is most of the time either it's a middle ear problem or external ear problem, not a inner ear problem. That means it is not a sensory neural deafness. Okay, that's why if you see this patient had a lot of gap between air conduction and bone conduction, definitely more than 10. So that's one of the things that you get in conductive deafness. Okay, but in sensory neural deafness, you will always find out there is like bone and air conduction is pretty much on the same area. So you can see that bone conduction and air conduction is same in this patient, but it is below the recommended, that means below 20 decibel. When you get something like that, that is sensory neural deafness. So when there is a less than 10 air and bone conduction gap, then it is sensory neural deafness. And if it is below the 20 decibel mark, that's easy to remember in that way. But still there is a lot in between, which I would not like to go through. Okay. All right, guys. So that's pretty much everything that I would discuss. The only other thing I want you guys to understand about the sore throat and sore mouth. So chapter 62 is sore throat. The only two things that comes in exam from here is tonsillitis and quinsy. So you can read this part by yourself. Streptococcal tonsillopharyngitis. So a patient coming to you with a sore throat, having fever, and then you have got tender cervical lymphadenopathy. Tonsil looks quite swollen and there is exudates or pus on the tonsil. No cough, having difficulty in swallowing, definitely because of the sore throat. Then you think of bacterial tonsillitis. So again, fever, sore throat or difficulty in swallowing, tender cervical lymph node, and tonsillar swelling and exudates. If you examine this patient, you will find out their tonsil is quite enlarged, inflamed, and there is a lot of pus, could be yellow-white exudates. That gives you the diagnosis of acute tonsillitis. Not everyone needs antibiotic, so you will give them if you have severe tonsillitis feature, like patient is quite unwell, toxic, can't even have any drink or food, then you would start antibiotic. Previous history of rheumatic heart disease, scarlet fever, definitely patient develops quinsy, or patient from aboriginal identities, they are the one which will definitely need antibiotic. So the treatment of choice for acute tonsillitis is phenoxymethylpenicillin, not augmentin. So phenoxymethylpenicillin should be given for 10 days. If patient is having penicillin allergy, you can try azithromycin or cefalexin. So how to know that it is quinsy or just tonsillitis? Quinsy means peritonsillar abscess. So patient will come to you with a feature of tonsillitis, but they will be more unwell because now there is an abscess around their tonsil. So patient will have severely high fever, 39, 40 degrees Celsius, with chills and rigors. They will have trismus, which means difficulty to open their mouth, drooling of saliva. And if you try to open the mouth, you will see there is an abscess in one of the tonsil, which is pushing the uvula to the opposite side. And that is pathognomic to diagnose quinsy. Okay, so trismus or difficulty to open the mouth, patient having constant drooling of saliva, looks very toxic and unwell, and the uvula is deviated towards the opposite side because of an abscess, that's peritonsillar abscess or quinsy. So for this patient, you'll need to send them to the hospital for a incision and drainage plus antibiotic. So antibiotic can be procaine, penicillin or clindamycin plus aspiration or drainage in hospital is the treatment. All right, so that's all about ENT today. And Dr. Pratik, about the question of 10-year-old girl has been referred for assessment of hearing loss because of difficulty in hearing. Her teacher in the school, bone conduction normal, air conduction pterosold reduced bilaterally. Weber shows no lateralization. Very unusual kind of information. I don't think that this is what is normal given in the exam. So ideally, they would give you a little bit more information in the exam because it doesn't look like anything is abnormal apart from a bit of low threshold air conduction. And even we can't diagnose anything specific, right? So the specific one, like your first option is perforation of the tympanic membrane, where you would definitely get a conductive deafness. So in that case, bone conduction rather than air conduction. Congenital deafness will be definitely diagnosed before 10 years. Autosclerosis uncommon in a 10-year-old girl, and again it gives a classic conductive deafness. Presbyacus is also very difficult, like very unusual for a 10-year. So you will go for a exclusion in here, and with exclusion it will come as like a chronic serous otitis media. It's not secretory, it should be serous otitis media with effusion. Lateralization is the loudness, yes. And Dr. Sharmin, we haven't discussed the ethics yet. Let me finish what I want to finish because I still want to go through imaging today. If I keep on answering all of your questions, then I can't finish what I want to finish and you will be just lagging behind. And lady with multiple neck swelling and ultrasound finding cystic lesion, what next? Okay, again, incomplete question, but multiple neck swelling, ultrasound. So if it is a cystic lesion, you would go for a FNSE or a aspiration cytology. That will be better because CT will not give us any other information about this. Ultrasound is usually the better for this. And look for, like, if they're talking about a multinodular goiter, if it is a multinodular, then we would go for a thyroid function. So for neck lump, for adult, you would go for a FNSE as the most important investigation, like the initial, and then if it comes back as something like a suspicious, then you go for a CT. So for any neck lump, there is a guideline of AJGP guideline for neck lump that you can follow. So that AJGP guideline really outlines everything that you need to know. But FNSE followed by CT is the treatment, is the investigation. Okay. So I want to start imaging today, even if we can't finish it, because we can't have more class for just the imaging for you guys. The classes that will be as scheduled has to be finished. Otherwise, we will not be able to finish it in the right time. Okay. Now that we are at the end of the course, the schedules will be followed very strictly, just because we want to finish everything that we want to. But if there is anything that you guys want me to finish, there is 2 classes that I normally take for anything is left out. So we'll be discussing that at that time, not during a specific class where we are supposed to finish a specific topic. So I would please advise anyone not to ask questions which is irrelevant to the schedule just because we want to finish things. Because if something is not able to finish, we would not be able to like just do that in your course. So I would definitely advise, let me continue so that I can finish what you really need. Like definitely you need to know what are the findings in the CT or X-ray, because it will come in the exam. Okay. Now imaging is very, very important because a lot of questions come in the exam in this case. So first of all, today I will try to finish the upper body, which means the CT scan of the lung, and then we will finish the other in some other class. So if you look over here, so CT again, you don't need to be a radiologist for this exam. You only need to be smart so that if there is something, you at least will know that this is the diagnosis. So you don't need to be a radiologist for this exam. That's my main advice to you, because many of you wants to know how can I diagnose a case of SVC obstruction by a CT. Now that is a radiologist's job. You will not be able to diagnose that. So don't ask those, and you don't need to waste your time for that. You need to know how a pulmonary embolism can be diagnosed by a CTPA, because that is important. Okay. So normal thing first. So in a CT scan, the bone fluids looks whitish, and anything which contains air will look black. So if you see over here, this is definitely the lungs. That's why it looks black. In the middle, you have got all the vessels. So you have got pulmonary artery. So this side is the right side, and this is the left side. And you can, with a CT scan, you can only look at a specific organ where the cross section has been taken. So you can't look at the whole body in one cross section. So in one cross section, you might be able to see the chest. In another cross section, you might be able to see the abdomen, like that. So in here, first of all, you can see the lungs, and then in the middle, you can see all the structures. So in here, if you go a little bit, if you take a little bit lower cross section, you might be able to see all the mediastinal structure. So this one is your main pulmonary artery, and pulmonary artery will be divided into right and left pulmonary artery. You have got this as your ascending aorta, and that will go down, and it's the descending aorta over there. In between descending aorta and the pulmonary artery, this small area that you see is the esophagus. This one is superior vena cava on the right side. And that's pretty much main structure that we can see in a CT test. Yeah, the vessels are a little bit grayish, you can say. Now that you know how the normal structures look like, let's go on, find out some abnormal structures. So first of all, pneumothorax, very important for exam. So always compare, because not always it will look like a very dark black. Sometimes it might be a little bit less black. So comparison is the main thing. Now, if you look here for pneumothorax, you can see that this is the lung shadow on the right side, which looks pretty good. There is vessels and everything, which is normal. This is the heart shadow, And on the left side, you can see that the lung is just up to this. So what is this black part? So air always goes up, right? So that's why you can see that this whole blackish part over there is the air accumulation. So always compare, that's the main thing. If you compare, you know which one is normal and which one is abnormal. So that's pneumothorax. Exactly the same is on this picture. You can see the right side is quite good, but the left side, the lung is up to this. Because all the air accumulation in the pleura is compressing over the lung. So that's pneumothorax again. Okay? Now come to this, interesting. Over here, the right side looks good again. The left side, you can see the lung shadow is like that, right? Now you see there are two lines. So there is definitely something there. And then there is also definitely something on this area. So air goes up and air looks black. So that is pneumothorax. And fluid or blood looks white. And blood, because it is a fluid, it will go down. So that is hemothorax. So this is a condition of left hemopneumothorax. Okay. What will be the management for hemopneumothorax? Hemopneumothorax. Chest tube. Yeah. Very good. Next. This is the X-ray. Tell me where is the problem? Or if it is just a normal X-ray. Okay, if you look over here, if you compare the right and left lung, there is definitely some abnormality because of the asymmetry. In a normal lung, you will always see these vascular markings. Okay, so these vascular markings are normal and has to be there. But if you compare the right lung with the left side, see that there is no marking you can see. It's just because there is like the most of the lung is covered by now like the air accumulation in the pleura, and you can't see inside the lung because of the pleural air accumulation. So when there is loss of vascular markings on the lungs, that's the time you can easily find out that this is pneumothorax. Okay. Now look at this one. The left side has got all the vascular markings, so that's good. But what you see here is called rim of air. You must have heard rim of air. So the rim of air is this. So you can see the lung shadow up to this, and after that there is no vascular marking. So that's also pneumothorax. Sometimes aortic dissection can come in the exam. And remember we talk about mediastinal widening in aortic dissection. This is the mediastinal widening. And you can see a prominent aortic notch or prominent aortic arch. So if you get this kind of prominent aortic arch with a mediastinal widening, it's an X-ray for aortic dissection. If they give you a CT scan and patient have like all the features of dissection, you can easily diagnose this. So remember the ascending aorta is over there, and this is the descending aorta. Descending aorta, you can see that there is definitely like blood in it, which it should be. But what you see here is the dissection. Okay, so when there is a tear, the tear can be very well seen on a CT scan like this. So there is a false lumen and a true lumen, and that lumen is divided by this line, and that is what we see in a dissection in a CT scan. So I'm just showing you the smart way to read it, because the hard way is difficult and you don't need to. Okay, but this is a smart way and very easy way to diagnose this in the exam. There is a condition called paraesophageal hernia or hiatus hernia. So in paraesophageal hernia, what happens is that the part of the stomach comes into the chest, right? Which it should not be. Remember, we told that between the heart shadow or the pulmonary artery shadow with the descending aorta, there was a small area that was the esophagus. If we go back to the initial one, so this is the area. So you should not see a lot of esophagus on a chest CT scan. But if you see this, what you see is that there is a very big lump, right? So when you see that there is a very big shadow in between the descending aorta and the either it's the pulmonary artery or the heart shadow, that is actually the paraesophageal hernia. And you can see the same over there as well. Doesn't come in exam often, but it's good to know. Now, this is the most important CT that comes in exam, pulmonary embolism. So if you look over here, so lung is good. This is the pulmonary artery. Pulmonary artery should have blood everywhere. But what is this blackish shadow? This is the area where the embolus is there, causing the lack of blood supply. So you can see a bit of emboli there. The whole of this is emboli. So that's how you would get in a pulmonary embolism CT scan. Okay, very important for exam. They usually give you this picture in the exam. And yes, it is right. So air is black in a CT scan, and X-ray, yes, X-ray also it will be black. So air is black everywhere. So that would be all the CT scan or X-ray that normally we would discuss. Now, few other things that I normally discuss apart from this, I'll just open up Google and show you a few things. So apart from that, we have discussed a few other lung X-ray is important to know. One of them is pleural effusion. So pleural effusion is not hard to get. So if you see here, so this lung has got a good outline, but what's happening there? So there is definitely asymmetry and you can see a concavity upwards. So this bit over there is all fluid. And that is what we get in a pleural effusion. Same like here, same like here. So it's all about checking for the symmetry. Okay, so that's a X-ray of pleural effusion. Then pneumonia. We did discuss that, like you get a consolidation. So you can see that there is a consolidation on the middle lobe. It's like bacterial pneumonia. And you can even see over there is a huge consolidation over there. This one has got multilobular consolidation. So you should know about the consolidation. We discussed that in the class. We also discussed how emphysema and a bronchitis X-ray looks like. But I will just go through with you. So when you have got a patient with emphysema, their lung will be very tall. So you can see the tall lung. So what happens in this patient? They starts to accumulate air in the lungs. And because they're accumulating more and more air, where it causes air trapping, patient starts to get a very black lung. So you can see the lung shadow is quite black on this X-ray. And sometimes you will also get, because it gets very tall, you can get a flat diaphragm and a long tubular heart shadow. So heart shadow will become more and more narrow. So when you have got a very black lung like this, tall lung, tubular heart shadow, and a flat diaphragm, that's emphysema. Sometimes it is not just a X-ray that will be given in the exam. Hemothorax will always have a stem of a chest injury. So hemothorax doesn't just happen. So if it is related to like a motor vehicle accident, more likely that it is a hemothorax. And pleural effusion doesn't come after trauma. So there will be some other kind of things, like maybe they're talking about a pneumonic effusion or a lung cancer. So it always depends on the patient as well. Okay. So it can look a bit same, but you will have a stem in the exam, and you'll be able to decide based on the patient symptoms and everything. Parapneumonic effusion, the same. So there will be effusion in a patient who is pneumonia. So it means that you'll just get the similar feature of a pleural effusion, but because patient is already having pneumonia, that's why we call it parapneumonic effusion. Sarcoidosis has been discussed in the class, and let's have a look. We talked about the hilar adenopathy. So if you look over here, you can see that this is called hilar lymph node. And if there is bilateral hilar lymphadenopathy, that's one of the main features that you look for in sarcoidosis. Okay, so you've got interstitial lung disease. So that's the ground glass appearance or reticular appearance. So that's what you get. So it looks kind of like a glass on the top of the lung, and there will be a small granular pattern. So that's reticular shadow or ground glass shadow that we can find in an interstitial lung disease patient. You can see. Okay. Doesn't come in exam, so silicosis, pneumoconiosis, X-ray will not come in the exam. If you know interstitial lung disease, that is more than enough. I think that's all that really needed. I can't recall anything really important apart from this on the chest X-ray. Okay. That's all for tonight, guys. I hope you learned things that you need for the exam. Again, this exam is not for being a radiologist, not for being a lung specialist. Just you need to know the basic. And I try my best to make sure you know the basic. Okay? His exam is February. No, it's not difficult in February. A lot of candidate from our course they pass in February. So if you are well prepared, there is nothing abnormal. So a lot of myth is there that February exam is difficult, different. It's actually not like that case. It sometimes depends on your luck, what kind of questions coming. But ideally, if you're well prepared, any month will be fine. Honeycomb doesn't need, it's not needed. You can have a look for bronchiectasis. So CT, they don't actually give you a lot of like a very, very difficult ones in the exam. For salivary gland, it's not very, very important, but there is a guideline called uh, diagnostic imaging pathway for salivary gland. So you can read that guideline about the salivary gland tumor. Here, there will be classes on ABG, CTG at the end. Okay? Same with the ethics, there will be class on ethics as well. All right, guys, so I'll finish it here tonight. Thanks, everyone. Have a good night. Take care.